The the thing to remember here again is that we're trying to identify those elements of information that we want to make sure that we're familiar with. And so, again, if you're hearing things that you're not familiar with, you want to make sure you put a star by that and know that this is something I've got to come back to and work on. Okay, in addition to the um, highlighting, just to identify it as important information. All right, so we are going to move on to page 49, which is assessment of the infant, page 49. You want to highlight letter A. Perinatal history is very important. Number one, remember the mother's history can give you an indication as to whether or not there may be some potential risk factors associated with the birth. Number two, mothers with diabetes, of course, are also prone to have premature and large for gestational age infants. And number three, family history, delivery and postnatal history is also very important information as well. Now, the good news is on the revised test, there's less questions about infant stuff because they've got a whole test on that now that they can test people who are really specialized in working with babies and pediatrics. So that's good news for you, but there are some basic things that you still have to know for this exam because there will be a significant number of questions that just won't be as many as there used to be. So highlight letter B there, terminology. These are some terms you should be familiar with. Highlight number two there, a term infant is born between 38 and 42 weeks gestational age. Number three, highlight that one. A preterm infant is less than 38 weeks of gestational age. Number four, a post-term infant is more than 42 weeks of gestational age. Number five, appropriate for gestational age or AGA. And this AGA, many times they will just use that definition and you're just supposed to know what it is, AGA. But if you see something that's abbreviated and they don't tell you what it is, oftentimes it's one of these abbreviations and it's associated with the neonatal population. Number six, large for gestational age or LGA, and number seven, small for gestational age, SGA. That brings us down to the box at the bottom of the page there, something I'm sure many of us are familiar with, and that is the APGAR score. I want you to highlight number two there. It is routinely done at 1 and 5 minutes. Highlight letter A, the 1 minute scores to identify how well the infant tolerated the delivery. And letter B, the 5 minute score identifies how successful our efforts were. Now, what I would call your attention to is this column here for number one. I would highlight that column there, all right? Because I'm one of these people, if there's too much information, sometimes I have a hard time remembering all of that. But if you know the score for a number, the score for number one is, then the score for number two is going to be worse than that, better than that. And then the score 0 is going to be worse than that. All right. So that's why I encourage people to focus on this column here and learn what the score of 1 relates to. So you can see here, if you have acrocyanosis under the appearance, that would be scored as a 1. So that's basically, peripheral cyanosis. If they're pink, there is no cyanosis, so that would be a 2. That's better. And then if there's central cyanosis, that would be on the body, that would be a 0. Okay. So this is worse. Here again, under the pulse, if the heart rate's less than 100, is less than 100, that would be a 1. If it's absent, it would be 0, which is really bad. Or if it's greater than 100, that would be good. Okay, so that's what I would focus on, looking at all of the things under here as far as how they would be scored as a 1, what the response would be. And from that, you should be able to determine, okay, is it better or is it worse? And be able to add a score or take away a score from it. Okay. At the very bottom of the page, this is a very important section, the action based on the score. So let's remember, if we have a 0 to 3, we're going to need to resuscitate the baby. If it is a 4 to 6, we're going to support and stimulate and warm and administer oxygen. If it is a 7 to 10, we're just going to monitor the baby and give routine care. All right, so that's a very important thing, because it's not just enough to be able to come up with a score. We need to know what we need to do with the score. And so that piece at the bottom there is very important as well. All right, that brings us to the top of page 50, transillumination, letter D. Highlight number 1, you're going to recommend transillumination when you suspect that there is a pneumothorax. And number 4, highlight that one. If there is a pneumothorax, then it's going to cause the entire hemithorax to light up. In other words, the entire thorax is going to look like a glow stick with this device. The purpose behind this is that it's a much quicker way, because usually getting the x-ray and getting them set up for the x-ray takes more time. Whereas this, you bring the light over, hook it up to the baby, plug it in, shine it on the chest, and if the baby looks like a glow stick, hey, I got a pneumo. And then you start getting your things ready to treat that. Under letter E, vital signs. The vital signs, again, for the infant are a little bit different than the adult. Highlight letter A, the normal heart rate should be 110 to 160, so keep that in mind. Number 3, the respirations, letter A, should be somewhere between 30 to 60 breaths per minute. And then number 4, the blood pressure, letter A, for a term infant should be about 60/40, which is about half of what an adult blood pressure is. Okay. And then number 5, the birth weight for a term infant should be greater than 3,000 grams. Now, when you think about birth weight on infants, another thing to remember is that birth weight is going to be used to determine endotracheal tube size. So I've got a couple of formulas here I want you to jot down in your book just to remind you, okay, what size tube would I put in this baby? So here's the formula, the first one. The first formula is 3.0 kilograms. Okay, 3.0 kilograms is equal to 3.0 endotracheal tube. Remember, 3.0 kilograms is equal to 3,000 grams. All right, so that's a term infant. The second formula is this. 3.5 kilograms, 3.5 kilograms is equal to 3.5 endotracheal tube. So if they're 3.0 kilograms, you're going to put a 3.0 endotracheal tube in. If they're 3.5 kilograms, you're going to put a 3.5 endotracheal tube in them. So again, birth weight, remember birth weight is used to determine what size endotracheal tube we're going to use. Top of page 51, letter F, cyanosis. We've already talked about what that is, but again, this is related to infants, and so we're just reminding you that is an important thing for you to be looking at and know what it means. Same thing with letter G, retractions, letter H, nasal flaring, letter I, grunting. Remember, grunting is the baby's way of creating and generating their own PEEP. Letter J, capillary refill. Once again, anytime you see capillary refill, you want to pay close attention to that. It needs to be take less than 3 seconds, okay, or 3 seconds or less to indicate good circulation or good cardiac output. Letter K, the Silverman score. Just need to know what it is. You don't need to know how to score it. That's assessment for respiratory distress. And letter L, gestational age. Number 1, the Dubowitz or Ballard method. You don't need to know how to calculate on this test. You don't have to calculate gestational age, but you do need to know how gestational ages are calculated. And they are calculated by either the Dubowitz or the Ballard method. And we describe those down there if you want, more information about that. All right. That brings us over to top of page 52, the pre and post ductal blood gas studies. Highlight number 1, if you've got a right to left shunt occurring across the ductus, then you're going to need to get some samples to verify what's going on here. And this is what you should find if you get a blood gas from the umbilical artery and the right radial artery, all right? Number 2, if the preductal, which is the right radial artery, PO2 is 15 torr higher than the postductal umbilical artery, which is the umbilical artery, PO2, then the patient has a patent ductus arteriosus or a right to left shunt. So again, you're going to get a sample from the right artery, right radial artery, and get a sample from the umbilical artery. And if the difference between those two blood gases is greater than 15, then that means, as far as PO2, that means that you have got a right to left shunt or a patent ductus arteriosus. And number 4, this is important. Again, to confirm that's what the problem is, you need to get an echocardiogram to determine the cause of the shunt. All right. Highlight letter N. The blood glucose. This is important to note in an infant. So highlight number 1. They're important for monitoring in infants. Number 2, term infants should have a value greater than 30. And number 3, premature infants should have a value greater than John's favorite number, 20. Letter O there, lung maturity information. Number 1, the lecithin sphingomyelin or LS ratio. Letter A, if you have a ratio of 2 to 1 or higher, that's good. Letter B, if the ratio is less than 2 to 1, then it indicates a high risk for HMD or IRDS, which of course are indicators that the lung is immature. All right, that finishes up the infant stuff. That brings us over to page 53, monitoring data. Monitoring data. The first thing we're going to talk about, again, monitoring our 2 life functions, our first 2 life functions, which are ventilation and oxygenation. And so that's why we're talking about letter A first, which is capnography. So remember, capnography is monitoring exhaled carbon dioxide, which is also referred to as ECO2 or ETCO2 and PETCO2. So highlight number 1, it measures exhaled carbon dioxide content using an infrared absorption. That might be just a recall question they ask you. How does it work? Number 2, once the capnograph is set up, an arterial blood gas is drawn to correlate the value. So you're trying to see how far off the blood gas is from this device. Highlight number 3, normally the end-tidal CO2 is going to be lower than the arterial CO2. All right. And so letter A, arterial CO2 should be around 40. End-tidal CO2 should be about 5 less, about 35. All right. Highlight number 4, the end-tidal CO2 can also be displayed as a percent, and the normal value for it is 3 to 5%. So make a special note of that. I'm going to slow down here for just a second and tell you about a situation I had on a tutorial session. Online tutorial. Student called, wanted to know why a particular question was wrong because he had picked that the patient was hyperventilating because they had an end-tidal CO2 of 5. And I said, well, yeah, normal is about 35, and at 5, that would be hyperventilation. And he says, well, why did I get it wrong? And I said, well, wait a minute, what were the units that you had? He said, well, the answer says percent, 5%, and that's what made it wrong. 3 to 5% is normal in a percentage expression. But if it was if it was 5%, 5 torr, that definitely is hyperventilation, looking at an end-tidal CO2 system. So make sure you pay close attention on the test. Is the units on the end-tidal, is it in torr or is it in percent? Because it will make a big difference, and they love to just flip those units around on the test. So be sure you pay careful attention to the units for the end-tidal value that they give you. All right. Highlight number 5, the sensor should be placed proximal to the patient's airway connection. Number 6, an increase in the end-tidal CO2 is going to indicate a decrease in ventilation, which means ventilatory failure. So you interpret it the same way you do in arterial CO2, all right? Number 7 is the end-tidal CO2. If you have a decrease in end-tidal CO2, that's going to indicate an increase in ventilation or a decrease in perfusion. And I want you to remember that if you have a sudden decrease in end-tidal CO2, I want you to be thinking about pulmonary embolism. Highlight those two words there, pulmonary embolism, in number 7. Okay, highlight number 8. If the capnograph reads low or 0, you need to think about reconnecting the patient or check for leaks. Number 9, a low end-tidal CO2 reading immediately following intubation would indicate that the endotracheal tube is in the esophagus. And then number 10, during CPR, the end-tidal CO2 should decrease. If it does not, then you're not doing adequate compressions. All right. So what we've got at the bottom of the page are some capnograph readings or graphs. You may be given one of these on the test. What I would like to do is just kind of walk you through it to make sure you know how to read it and know what it means. So this graph basically has time on the horizontal axis and then an end-tidal CO2 in torr or millimeters of mercury on the vertical axis. Basically what happens is when the person exhales out, you should see a rise in the CO2 in the system. When they take a breath back in, it comes back down. Okay, when they exhale back out, it should go back up. So each one of these waveforms would indicate an actual respiratory cycle or a breath. Here we know this is normal, not because we got a normal respiratory rate, but because our CO2 is about 30. Okay, so the normal range would be somewhere, around 30 to 35, somewhere around there. Okay, so this will be considered normal. Here in the second graph, we can definitely see there's more breaths, which would tend to indicate maybe there's some hyperventilation going on. But to know for sure, you got to read how much CO2 is being exhaled, and you see it's right here at 20. So that's a very low amount of CO2 being exhaled. So that would be consistent with hyperventilation or an increase in dead space. Okay, if you saw all of a sudden the patient's graph drop down below from what it was, you need to be thinking, hey, are they breathing faster, or is it because there may be a pulmonary embolus? The third example here is an example of an obstructive pattern. And the way we know it's an obstructive pattern is because it's taken a lot longer to exhale out, right? And not only that, but look at the value. It's right around 45 to 50 torr as far as the exhale. So that's definitely a COPD-er, all right? The next one down is an example of what may look like if you have a leak. And again, you notice that it's just a straight line. There's no waveforms that would indicate a respiratory pattern. So you need to verify that the patient is either is still breathing or that they are actually still connected to the device. All right, so those are a couple of waveforms that you need to be familiar with. Top of page 54, highlight number 11, moisture and secretions can cause false readings and obstruct the sample tube, and the device is going to read 0. Number 12, there are other types of CO2 detection devices. We give you several examples down there in the pictures. A monitor, full-fledged monitor, and then of course the colorimetric device. Remember on the colorimetric device, letter C there under 12, that purple is poor and yellow or gold is good. All right. Down at the bottom of page 54, number 13, this is a new item on the exam. Quality control for these devices. Highlight letter A, calibrated with room air, and then 5% CO2 concentration. So you need to make sure the device has been calibrated. And then letter B, it should be calibrated every 8 hours. And then letter C, the CO2 value from the blood gas should be compared with the capnograph when taking a reading at the time of sampling, which I think we've already mentioned that. All righty. That brings us to the top of page 55, oximetry. Under number 1, highlight letter A, pulse oximetry. Letter A, this is the most appropriate non-invasive technique for continuous monitoring of oxygen sats and pulse. Letter B, the normal range is 93 to 97%. Drop down to letter G, the accuracy is affected by poor perfusion. Some examples of that would be shock or hypotension and conditions that interfere with the light transmission. That would be conditions like erythema, bright ambient lights, and so forth. Letter H, pulse oximeters are going to read a higher saturation if carbon monoxide poisoning is present. So let me pause here for a second, make sure you heard that. If you're suspecting a patient with carbon monoxide poisoning, this device is not going to be helpful in you managing whether or not they've got enough oxygen on board. All right, so pulse ox and carbon monoxide poisoning do not mix. We'll talk about the carbon monoxide poisoning and a little bit more on how you monitor oxygenation status for that. Letter I, again, this is some new information that's on the test or being tested, and that's the quality control. Once again, number 1, you need to know that the pulse ox is calibrated by the manufacturer. Number 2, it's accurate for oxygen saturations greater than 80%. And number 3, saturation is less than 80% should be confirmed by blood gas analysis or hemoximetry. That brings us over to top of page 56, number 3, co-oximetry and hemoximetry. Now, let me just pause here for just a second and say that again, co-oximetry, the term co-oximetry and the term hemoximetry, they both mean the same thing. Most people have heard of co-oximetry, but may not be quite as familiar with hemoximetry. And so I'm just cautioning you to make sure you know that they both mean the same thing. It's the same device. They do have the same purpose. All right. It's just two different ways of saying things. So look at letter A. The co-oximeter or hemoximeter is used to diagnose carbon monoxide poisoning. Letter B, the normal carboxyhemoglobin should be 0 to 1%. And then letter D, CO poisoning is a carboxyhemoglobin greater than John's favorite number, which is 20. All right. And basically what you need to do is anybody has a CO poisoning greater than 20, you need to be using 100% oxygen, and you also need to use hyperbaric therapy if it's available. All right. Letter H, this is an invasive and non-continuous measurement, so that you have to draw the blood gas. You just draw the blood gas like you normally do. You're just running it through a different piece of equipment. However, I will qualify that by saying that many hospitals have one machine that has a built-in co-oximeter with it. So while you're getting your blood gas stuff, you may be getting your co-oximetry or hemoximetry reporting out at the same time. But the MBRC is a cheap hospital, and they like to have separate pieces of equipment for their blood gas analyzer and their hemoximeter. So that's why they typically will ask you questions separately about that. All right, you can kind of read down through the rest of that on page 56. That brings us over to the top of page 57. Transcutaneous monitoring. A couple things to remember here. Highlight number 2. we need to heat the skin around the electrode to about 43 to 45 degrees Celsius. And whenever you do that, that enhances the capillary blood flow and thereby makes the sensor able to pick up the oxygen levels more easily. All right. So drop down to number 6. The electrolyte should be changed every 4 hours. If redness or blistering of the skin or erythema occurs, the electrode is moved to a new site more often. So once again, let me pause for just a minute here. Make sure you heard this. This electrode's got to have a temperature maintained between 43 and 45. If it doesn't, then this vessel is not going to dilate and this device is not going to work. So if you've got a problem with the skin getting blisters, you do not turn the temperature down. If you turn the temperature down, this device will not work. What you have to do is you just have to change the site more often. Instead of changing it every 4 hours, you may have to change it every 3 hours. All right? So that fixes that particular problem. But I'll promise you, they will probably offer you turn the temperature down. But if you turn the temperature down, then they know that you don't understand how this thing is supposed to work. So always choose with a transcutaneous monitor the option of changing the site more frequently to fix the problem of skin blistering. All right. Number 7 is also new information to the test quality control. Highlight letter A, you're going to calibrate your PaO2 electrode to a high and low level. Usually, again, to room air, that would be at about 150, and then the electronic zeroing solution, you put that on there and it takes the PaO2 down to 0. So you're going to calibrate it pretty much in a similar fashion as a oxygen analyzer. All right. Letter B, calibration of the CO2 electrode. There will be a high gas and a low gas. Again, calibrating it to a high value and a low value. Letter C, electrode should be calibrated before the initial use and whenever the electrode is repositioned. So that's going to be about every 4 hours, right? Letter D, ABG values should be compared with transcutaneous readings taken at the time of sampling. So that's just to kind of make sure that, you can kind of see what the variation between the two readings are between a blood gas and the actual monitoring device. Okay, that's going to bring us over here to hemodynamic monitoring. Now, here it is, almost 4 o'clock into the day, and I'm talking about hemodynamic monitoring. Normally, this doesn't take place until right after lunch, and it usually gets a lot of moans and groans. So I'm sure that some of you are out there moaning and groaning right now, the fact that, this is towards the end of the day, and here we are talking about hemodynamic monitoring. But I want to take this pause to give you some encouraging news. I taught hemodynamics for probably, 15 years at my college, and I enjoyed it. I mean, I liked it. But a lot of the students that took the class, they always moaned and groaned. But the good news is that whenever by the time they got finished with it, they weren't moaning and groaning because they felt more comfortable with it because we did a lot of practice. All right. Now, whenever I was going through my orientation, and I have to be careful what I say here because Tom was the guy that oriented me. When I was going through my orientation for the seminar and got to the hemodynamic part, after he'd done his presentation on it, I came up to him at a break or at the end of the day, I can't remember which. And I said, Tom, I said, the hemodynamic session, I got a section, I've got a couple of questions. He said, sure. So I said, well, I noticed you didn't talk about, this particular aspect of hemodynamics, why is that? And he said, well, it's not on the test. And I said, well, I also noticed you didn't talk about this, it seems pretty important. I said, why didn't you talk about that? And he says, well, it's not on the test. I said, well, what about this thing over here? He said, John, it's not on the test. I said, so let me get this straight, Tom. We're only supposed to talk about what's on the test. He said, right. So hemodynamic monitoring on through Kettering, you can get the basics of it down in probably, 45 minutes or less. Okay. So that's good news because there's not a lot that you have to know about hemodynamics for this test. And what I'm about to share with you on page 58, if you understand page 58, when we get finished with page 58, if you can honestly look at yourself in the mirror and say, yeah, that makes perfect sense to me, then you have got the hardest part of hemodynamics done. Okay. And now all you need to do is just practice it a little bit. Okay. And we're going to give you some routine and some strategies on how to approach it as far as interpreting it and looking at the information. All right. So I'm telling you all of this because I know how most people react whenever they see that come up on the screen, hemodynamic monitoring. Most people will just say, man, I didn't get it in school. I'm not going to get it now. And so I'm just going to tune out for the next bit. And what I'm asking you to do is there's a lot of hemodynamic stuff on the test. And so if you're good at it and if you can do it the way that we show you, you're going to see a tremendous improvement in your score. And so what I'm trying to do here is to pique your interest just a little bit to kind of keep you engaged a little bit longer before we finish up the day, to give you a real gem of information that you can use in the future on this test. Okay. And I'm telling you, after I went through it the first time myself, I was totally blown away. And I said, man, I can do that. And whenever I actually went and took my test, I did it exactly the way Kettering showed me. And it was just so easy. It just kind of went right through it. I thought I was in a Kettering seminar. So, that being said, let's walk through this together. But again, I'm asking for those of you who are really frustrated about hemodynamics to keep an open mind as we go through this. And I think you're going to find um, a good bit more peace with it after we go through it the Kettering way. Okay. All right. So top of page 58, let's look at letter D, hemodynamic monitoring, number 1. Remember, hemodynamics simply refers to the third and fourth life functions, which are circulation and perfusion. All right. So remember, because we're talking, these hemodynamics tells us about circulation and perfusion, those are 2 life functions. So my question to you is, do you think this is important on the MBRC exam? You better believe it. But like I said, the good news is it doesn't have to be hard. Just got to understand some basic principles. Okay. So drop down to letter E. And let's talk about physiology of blood pressure. Let's talk about how blood pressure is controlled. And it's really only controlled by 3 different things here. Okay. And if you understand how blood pressure is controlled, then you've really got the essence of what hemodynamics is all about, because all we're looking at is how blood moves through the body. That's all we're looking at. Okay. So let's look at number 2 there. It says, number 1. Without sufficient blood pressure, the cells will not receive oxygen and nutrients if they need to survive. Now, if that makes sense to you, that's great, because that's a very important concept to understand. So blood pressure is very important here. Number 2, high blood pressure causes a strain on the heart and will eventually cause the heart failure and increases the risk for more stroke. Now, I've heard that before, and that makes sense. All right, so I'm doing pretty good so far. Number 3, there are 3 factors that control blood pressure, and the first one is heart. We just mentioned that, okay? So under letter A, let's highlight number 1. If we have an increase in heart rate, that's going to increase blood pressure. Yeah, I've heard that before. Whenever I run up a flight of stairs, my heart rate goes up, and if you were to check my blood pressure, it would be up. Okay, so yeah, that makes perfect sense. All right. Letter A under there, chronotropic drugs or drugs that increase heart rate can also increase your blood pressure. All right. Number 2, a decrease in heart rate will decrease blood pressure. Look at letter A there. Beta blockers, beta antagonist drugs, Those are all going to decrease your heart rate and can cause your blood pressure to go down. So again, if increasing your heart rate makes your blood pressure go up, decreasing it should make it go down. That makes perfect sense to me. All right. So rate can have a big impact. Heart rate can have a big impact on blood pressure. That's the take-home message here. All right. Look at number 3. An increase in contractility will increase blood pressure. If the heart muscle squeezes harder, that's going to make your blood pressure go up. Does that make sense? Yeah, that makes sense. Look at letter A, drugs that can cause an increase in contractility, digitalis and digoxin. That makes your heart squeeze harder. So those drugs can make your blood pressure go up. Well, if an increase in contractility makes your blood pressure go up, number 4, highlight that, a decrease in contractility is going to decrease your blood pressure. And that would be like what occurs in CHF. And there are some medicines that you can give for decreasing contractility. Those would be things like your calcium channel blockers. All right. But again, if we decrease contractility, that decreases blood pressure. That's usually not a good thing. So that's how the heart can change blood pressure, by changing the rate or changing how hard it squeezes. How do you feel about that? Yeah, me too. I'm right there with you. I get that. That makes perfect sense, doesn't it? Okay, let's continue on. Letter B. So the next thing that can cause a change in blood pressure is the blood volume here. All right. So let's see how blood volume affects blood pressure. Number 1, if we have excessive fluids, then that's going to increase blood pressure. We've already talked about this a little bit, and we're going to treat that with diuretics like furosemide to get the blood volume down. That makes sense. And number 2, if we have a loss of fluids, that's going to make our blood pressure go down also. And so that means we either lost blood or lost fluids, so we're going to treat those situations with more fluids or blood products, depending upon, what the circumstance is, if we need more hemoglobin on board or whatnot. So yeah, increase fluids is going to increase my blood pressure, decrease my blood volume or blood fluid level is going to cause a reduction in blood pressure. That definitely makes sense to me as well. And I hope it does to you as well, you too. The last thing is the vessels. All right, letter C. And this has to do with, is the vessel dilated or is it constricted? And you can see here, number 1, we start off with vessel constriction. So if the vessel is constricted, that's going to cause an increase in blood pressure. If we have an increase in blood pressure, then we give you letter A. How are you going to treat that? You would treat it with vasodilators. And the vasodilator that I want you to highlight there is under Roman numeral 1, nitroprusside. That's a common one that's used in the intensive care unit. And you may see this drug on the test. All right. So it's used for lowering blood pressure. That's a vasodilator. The other thing, number 2, at the bottom of page there, vessel dilation. If you have vessel dilation, that can actually decrease blood pressure. So if you have a decreased blood pressure, how do you treat that? Well, you treat it with vasoconstrictors. And examples of the vasoconstrictors we want you to remember are highlight epinephrine, highlight dopamine, and highlight dobutamine. Those are vasoconstrictors you want to think about on the test. Now, a couple of notes about those 3 drugs. Epinephrine, I want you to write this note underneath it. Not good if heart rate is increased. Not good if heart rate is increased. Because remember, what does epinephrine do? It makes your heart rate go up, right? And so if your heart rate goes up, and then, if your heart rate's already up and you give the epinephrine on top of it, then the heart rate's going to beat way too fast. It's not going to have time to fill, right? And that's going to affect your blood pressure. It's going to go down. Okay. Dopamine and dobutamine. I want you to draw a little bracket between those 2 underneath them, and I want you to write this phrase. More often used in the ED or emergency department in ICU. So dopamine and dobutamine are more often used in the emergency department in the ICU for raising blood pressure, for elevating blood pressure. So that's an important thing to remember. Okay? Now, letter F at the very bottom there, systemic blood pressures. We've already talked about two of these pressures already. For the adult, the normal systolic blood pressure should be 120. Letter B, the diastolic pressure should be 80. All right. Now, there's one other blood pressure you need to add to that list, and that is your mean blood pressure, which should be about 90. It says 93 here, but I just round numbers make it easier for me to remember. So, and there's another place in here where it talks about in the study guide that calls it 90. So I just remember around 90. Okay. All right. So there you have it. That's the foundational piece of hemodynamic monitoring for Kettering. How do you feel about that? Does that make sense? What can make blood pressure go up and what can make it go down? That's really the only thing that you have to understand at this point, okay? Now, we're going to build on this a little bit and add some pieces, but we're not going to change this theme, all right? The theme is the same. We need to know what's going on with blood pressure, all right? That's the theme. Look over to page 59, where letter G, where it talks about the transducer, okay? You do not have this slide in your book, so if you want to take a picture of it or take a screenshot of it, feel free to do so. I just do this for me because I'm a visual person and it makes it a lot easier for me to understand what's going on here. Okay, so what we've got here is we've got a patient that's lying flat. Here's the transducer for monitoring their blood pressure. All right. And again, they got the level there. They want to make sure that this transducer is level with the heart. So that's what we're talking about here. Why are we leveling the transducer? Here's the reason we're leveling the transducer, because you come over here, what I did is just kind of put an A line so you can kind of reference it to these things right here. These are transducers. All right. And this little line right here is just this is the tubing that goes between the transducer and the A line. All right. So this is just kind of give you a reference of what we're talking about. This over here is the meat of what I wanted, the point I want to make for you. Okay. So let's say, for example, under number 4, letter G, number 4, top of page 59, it says that the transducer should be at the same level as the tip of the catheter. So that's what we're talking about here. Okay. That's the transducer. And then it says letter A, if the transducer is above the catheter, so here's the catheter and here's the transducer, it is above the catheter, then what that means is if the transducer is above the catheter, that means that the pressure is going to read lower than actual. So that means that this device is not going to be accurate. If you see that it says the blood pressure is 120 over 80, then that means that's not right. The blood pressure may be 140 over 90 because this transducer is not level with the patient's heart, okay, or not level with the catheter, okay? So the point is, if the transducer is not level, it's not accurate. If for some reason the transducer is above the A line or higher than the A line, then that means that the transducer is going to read lower than what it actually is, all right? And the reason for that is because if this is the transducer and here's the A line, gravity is going to pull fluid away from the transducer. And so therefore there's going to be less pressure on the transducer. That's the reason why, all right? On the flip side of that, if the transducer is below the A line, like it is here, okay, now everything's revealed in the slide. So if you want to take a picture of it or screenshot of it, feel free to do so. If the transducer is below the A line or below the catheter, then the pressure is going to read higher than actual. And the reason for that is because now gravity is pulling the fluid towards the transducer from the A line, and that actually creates a rise in pressure. And what I tell people is, sometime if you're in the unit, you can kind of do this if you want to with your patient. Just kind of raise and lower their arm of the A line above and below the transducer and watch what happens to the waveform on the monitor. What I used to do is I would make this transducer go up and down in my class, and you could actually see the waveform change on the monitor just by the way I was moving it. So again, the take-home point here is, in order for the transducer to be accurate, it's got to be level. That's the take-home message. All right. Now, middle of the page there, you've got a waveform. Again, this is a typical arterial waveform that's got a diacritic notch here. We'll talk a little bit more about that in just a minute. But again, that transducer is taking mechanical energy and transmitting it into transferring into electrical energy so it can be used to project a waveform on an oscilloscope is what it's trying to do there. All right. Now, page 59, excuse me, page 60. We've got an illustration at the bottom there, but before we get to that, I want to go to the top of the page 60, and I want you to highlight letter B. And letter B says that the mean pressure in the systemic arteries is normally 90. All right. Remember, I told you, I said we got another place that says that it's 90. Well, this is where it says it's 90. And I like this one better because it's a round number. Okay. So you just need to know the mean blood pressure in the systemic circulation is going to be about 90. Drop down to letter D. We've already talked about this once before about right atrial blood pressure, or CVP, same thing. The pressure, normal pressure for that is 2 to 6 millimeters of mercury or 4 to 12 centimeters of water. All right. And if you look at both of those, you can see that if we convert from millimeters of mercury to centimeters of water, all we have to do is double the numbers. All right. So again, just some numbers. We need to know numbers because, and we'll find that out here in just a minute. We got to know numbers because in order for it to make this hemodynamic stuff make sense, we got to know whether the blood pressure is going up or the blood pressure is going down. So you got to know blood pressure numbers. All right. And we're going to get to those right now. That's what this illustration is. This is what I thought was so cool about the Kettering seminar that I attended, is whenever Tom went through this, because it was like, wow, man, that is just so cool, and it's so easy to remember. It makes it so easy to use for answering the questions on the test. Okay, so let me orientate you a little bit to the diagram so you kind of know what's going on here. What we're showing is a representation of blood flow through the body. All right, so we're starting off over here in the left ventricle, going out through the aorta, down to the capillaries, coming back through the venous system up to the right atrium, and then going into the right ventricle, and then from there into the pulmonary circulation, the pulmonary arteries, and then through the lungs, or the capillaries in the lungs, and then back through the veins in the pulmonary system back to the left atrium. Okay, and of course it just keeps circulating all the time. Now, what we need to know is, remember I told you need to know blood pressures in order to understand hemodynamics. So I want you to write these blood pressures in as we go around the diagram here in the locations on the screen. So follow the screen carefully. Right? We're going to start off down here. Or actually, I think we start off down over here to the right. So the systemic arterial blood pressure is 120/80, and that's millimeters of mercury. And then the mean arterial pressure, or MAP, is 90. Write those in on that line right there. Okay, 120/80 in parentheses 90. That's the mean. Okay. Come over here to your CVP box. We've already told you what the normal values are for CVP. It's 2 to 6 millimeters of mercury or 4 to 12 centimeters of water. So it could be either one of those. Make sure you know both of those numbers. Again, you got to know these blood pressures to know whether or not the blood pressure is going up or down to figure out what the problem is. All right, so it's very important you know these blood pressures. Go up here to the pulmonary arterial system, PAP, and these are the values that go up here, 25/8 with a mean of 14, okay? A mean of 14. And what I would like for you to do is just draw a circle around that 14 millimeters of mercury, draw a circle around it, and draw a line up here towards the middle, and put mean in the teens. Just write that little phrase up there, mean in the teens. That just reminds me, mean in the teens, if I see this other than something beside in the teens, it's not going to be normal. All right. Come over here to the pulmonary venous system, pulmonary capillary wedge pressure. and that is 4 to 12. That's the range for it. And that's an easy one to remember because 4 to 12 has already shown up in this diagram once before, hasn't it? Right down here, right? So just know that the wedge pressure is the same as the centimeters of water pressure as far as the numerical values, 4 to 12. So that's easy to remember too. All right. So again, let me say this carefully and make sure you get this. You've got to know these blood pressures to interpret pulmonary, hemodynamics on the test. If you don't know these numbers, you're going to be totally lost. Okay, they're not hard numbers to learn. And again, if you think about them in terms of this diagram, it'll really help you to lock in on what's important for the test. All right. Now, what we're going to do is we're going to put some titles over these boxes. And so the first title is going to go down here over the CVP box. And basically what it's saying here is, I want you to write these titles, right heart problem. So this is saying that, hey, if we've got a problem with our CVP pressures, if our CVP pressures are not where they're supposed to be, that means I've got a right heart problem. Okay? Right heart problem. Go back up here to the pulmonary arterial system. And if there's a problem with these blood pressures right here, then I've got a lung problem. Because again, pulmonary, lung, that's a lung problem. All right. Come over here to the pulmonary capillary wedge system. And if I've got a pulmonary capillary wedge system problem, that is a left heart problem, because basically that's being measured right over here towards the left heart. All right. So the pulmonary artery is being measured here, okay? But the wedge pressure is actually being looked at all the way over to this side of the lung, okay? So it's actually looking at the left atrial pressure, all right? So once again, if I've got a problem with my CVP, I got a right heart problem. If I've got a problem with my pulmonary artery pulmonary artery pressure, then that is a lung problem. If I've got a problem with my wedge pressure, that is a left heart problem. All right. And that really is the meat of what you've got to know for the MBRC exam right here on this diagram. All right. If you've got that part down, then you're going to do fine on the test. Okay. Because the rest of the stuff we're going to talk about is just going to point right back to this stuff. All right. Okay. I'm hoping there's no questions at this point, because I'm sure if there were, Tom would have jumped in here by now. All right. So let's move on to the top of page 61. Let's talk about the waveform. The waveform, the catheter position and waveform. You're going to need to be able to be familiar with what these waveforms are and represent, or what they may represent as far as location. Where are they at? So this is a tracing of a catheter, a pulmonary artery catheter that's being placed in the patient, being started off in the right atrium and goes all the way through to the wedge position. Okay. And so what they do is, of course, they put the catheter in place through the subclavian vein or through the jugular vein and in the neck, and they float the catheter into the right atrium. Then they inflate the balloon, and then they float it through the right ventricle. And when they go into the right ventricle, they get this waveform. Whenever they go into the pulmonary artery, they get this waveform. All right. And when they get over into the pulmonary capillary wedge position, they get this waveform. All right. So the biggest thing to remember about all four of these waveforms is this one little piece right here in the middle, and that is this dicrotic notch. When you see that dicrotic notch, that represents you're in an artery. Okay. In this case, because you're hooked to a pulmonary artery line, it's a pulmonary artery that you're in. All right. So this dicrotic notch is very important to identify. When you see that you know that the artery position is in the pulmonary artery. Now, what typically happens is, once it passes through the pulmonary artery and they float the catheter out with the balloon inflated into the wedge position, then that is the wedge, capillary wedge pressure, and they can measure it and take that pressure and write it down and use it for what's going on the left side of the heart. However, they can't leave that catheter inflated. I mean, the balloon inflated. They got to deflate it. And when they deflate it, this just continues on. Okay, it goes back into the pulmonary artery pressure waveform. So you never see this stuck up on the monitor continuously. You always see this stuck up on the monitor. Then somebody comes in, inflates the balloon, and then it changes to this. When they deflate the balloon, it changes right back to what it was. Okay? So here's the piece you got to know. These two waveforms, this pulmonary capillary wedge pressure sometimes looks very similar to this right atrial pressure. And on the test, they may ask you, well, what is this waveform representative of? And the only way you're going to know is by knowing what the waveform is that's next to it. So if you see the CVP pressure and you see a waveform that's next to it that has no dicrotic notch, you know that is the right ventricle. So if there's no dicrotic notch next to it, that's got to be a CVP pressure. All right. However, if you're over here and you see a pulmonary capillary wedge pressure and you see dicrotic notches waveforms before it, or you see dicrotic notches waveforms after it, then you know that's got to be a pulmonary capillary waveform. All right. So whether or not you have dicrotic notches or not is going to clue you in as to what this waveform is. And usually they got to give you two pieces. They got to give you this with this, or they're going to have to give you this with the after waveform, after you deflate the balloon. Okay. And again, if the waveform is next to a waveform that has a dicrotic notch, it's got to be a pulmonary capillary waveform. If it's a waveform that does not have a dicrotic notch, then it's got to be a CVP waveform. All right. And I know some people say, well, yeah, well, this one's just a lower pressure than this one. Well, that's true, but sometimes this pressure can be higher and look almost the same as a wedge pressure. So you can't just go by the pressure that's in here. You've got to look at the whole picture as far as what waveforms are next to it. So that's what I'm encouraging you to do. All right. And so underneath that, you can see, you can highlight numbers 1, 2, and 3. That's kind of my explanation of what's going on there. Letter J, we've already talked about the dicrotic notch and what it represents and the importance of it in this particular illustration. So we can move on to that. Now, as soon as I get over to this picture, this is when everybody calls me a liar. You said this is going to be easy, John. And there's that daggum table again with all them arrows up and down. That's the thing that just bugs me to no end, John. How can this be easy? Well, let me tell you how. I want you to disregard everything about this box for right now, because all I'm going to tell you is that this box points back to the circle diagram. All right. Remember the circle diagram? That's the circle diagram. All right. So that box is pointing back to this. So if you understand this, the box is not going to be, I mean, it's saying the same thing. The box is saying the same thing as this. Okay. And watch what I'm talking about. So the first thing I want you to do is I want you to go through this box and I want you to circle everything that has a double arrow. Everywhere there's a double arrow, I want you to circle it. Okay? I'm just going to give you a minute there to do that. And I'm going to take a drink of water while you do that. Everywhere there's a double arrow, circle it in this box. Okay? All right. That shouldn't take you very long. So what we're going to do is I'm going to show you where you've circled. The first one here, the double arrows here. This is the CVP column, right? Now, when we said that when we have an elevated CVP, what kind of problem do we have from our circle diagram? What did we say? What kind of problem we would have? That's right, a right heart problem. Okay. Now, so all this does is give you examples of what right heart problems are that may be on the test. So look over here, right heart failure. Is that a right heart problem? Oh, yeah. Corporal anomaly, is that a right heart problem? Yeah. Is tricuspid valve stenosis a right heart problem? Well, the tricuspid valve is in the right heart. So again, this picture, when you see it on page 62, just remind yourself this is pointing back at the circle diagram. It's the problem is with where the double arrows are. So I got to find the double arrows to find out what the problem is. Problems CVP, that means I got a right heart problem. What are examples of right heart problem? Here they are. Those are the ones that may be on the test, okay? Next double circle is right here. And we said if we have a problem, again, double arrow means I got a double problem with the PAP. If I got a problem with PAP, what kind of problem do I have? I've got a lung problem, okay? So what are some examples of lung problems? Well, we've got them listed right over here. Lung disorder, pulmonary embolism, pulmonary hypertension, air embolism. Those are all lung problems. And notice most of them start with the word lung, okay? Where's my next circle on my double arrows? Right here. Well, I said, okay, if I've got a problem with my pulmonary capillary wedge pressure, what kind of problem do I have? I said I had a left heart problem. What are examples of left heart problems that are going to be on this test? Here they are. Left heart failure, mitral valve stenosis, and CHF. Okay, so those are the problems. Now, because again, most of the time on this test, so I'm going to show you some questions here in just a little bit. We'll practice and show you how they're going to ask the type of question. But most of the time, you just got to be able to identify what the problem is, and then basically you're going to be asked how to fix it. Okay, and we'll talk about that here in just a minute. These last two are the simplest of all of them. Anytime you see all of this, if you see the CVP up, if you see the PAP up, if you see the wedge pressure up and the cardiac output up, if all the hemodynamic values are up, then that means, that means I've got hypervolemia. I got too much fluid, so I need to give furosemide, right? Get rid of it. And then if all of the values are pointing down, that means I've got hypovolemia. And that means I need to give fluids, right? Or blood, depending upon what the situation is, okay? So, I mean, that's pretty much what you need to know for interpretation of hemodynamic on the test. Now, we've got just a couple of calculations we need to know about hemodynamics on the test. And I know what some of you are saying, oh, great, hemodynamics with math. Once again, I'm asking you to be very patient, okay? Don't let the math scare you. Most of the math is going to be pretty simple here, all right? And if it gets out of hand, you don't have to worry about it because like I said, you can go take a break at any time, all right? So additional hemodynamic assessments, the first one there, top of page 63, are the pulse pressure. So highlight pulse pressure. And you see the formula for pulse pressure is letter A. That's systolic pressure minus diastolic pressure. That equals pulse pressure. And so that's important to know if we're moving blood. We got to have a gradient in order to move blood. All right. That's a pretty easy one to remember to do. Systolic minus diastolic. The next one is the mean arterial pressure. Now we've talked about mean arterial pressures, what the normals are for pulmonary artery, mean in the teens. And then for the systemic, around 90. Okay, for the systemic map. But how do we calculate it? You may be asked to calculate this on the test. And so it's very easy. All you got to do is take 2 times whatever the diastolic pressure is, add it to the systolic pressure, and then divide it by 3. All right? That's pretty much a standard formula for calculating the mean. All right? And again, you may be asked to do that once or twice on the test. So that's an easy one to remember. 2 times the diastolic plus the systolic. All right. The next thing there, number 3, is cardiac output. And we've got a equation there, a Fick equation. I'm just going to go ahead and tell you, John doesn't do Fick equations. All right. You can do the Fick equation if you want to, but John doesn't do Fick equations. I don't know what it is about a Fick equation, and I got to be careful about saying this since Tom's listening. But me and the Fick equation don't really get along too well. And I usually get all confused about what goes where. And then as a result of that, my anxiety level goes up on taking the test. And then when my anxiety level goes up, I don't do very good on the rest of the test. So again, part of the process of taking this test is managing your anxiety. And so for me, I'm willing to miss a question on calculation of a Fick equation, okay, as opposed to getting myself all anxious and then messing up on all the rest of the test. All right. So there may be something else out there that you won't do, and that's okay. Maybe it's pulmonary functions or some other formula or something like that. But for me, it's the Fick equation. I just know the Fick equation measures cardiac output. I know what the normal cardiac range is. So highlight letter D, 4 to 8. And so if the blood pressure and the information in the formula looks right, then I'm probably just going to try to pick a normal value is what I'm going to do, 4 to 8. All right. Number 4, the cardiac index. That's a pretty simple formula to do there. In the middle of page 63, it's equal to the cardiac output divided by the body surface area. Again, they will give you the body surface area. You need to know what the normal value is. The normal value is 2.5 to 4 liters. And that's an easy one to remember because it's about half of what the cardiac output is. All right, you may want to write that off to the side there, about half of cardiac output. So if you remember what normal value is for cardiac output, just take about half of it and you'll be pretty close to what your range is for your cardiac index. Number 5, systemic vascular resistance. This one here, SVR. There's a formula, and a lot of people say, yeah, that's my Fick equation. Well, that may be your Fick equation, but let me talk with you about this a little bit and how to set this formula up and why I think it makes so much sense. Okay. There was a time in my life whenever I took geometry, and geometry made no sense to me. I mean, in high school, all those theorems and proofs, I had no clue what was going on. I just couldn't get it. Till one day in class, the instructor put up on the board that we're going to be talking about the Pythagorean theorem. And I'm thinking, oh, great, another theorem. And then he writes up on the board, a squared plus b squared equals c squared. And I looked up there and I says, now that makes sense. That makes sense. I got that. And I've never forgot it. Okay. And so for me, when I see SVR and PVR, pulmonary vascular resistance and systemic vascular resistance, resistance makes sense to me. I understand resistance. Okay. And the way I think about resistance is the same way you were taught to think about resistance, and that is with this right here, airway resistance that's on the screen. Okay. Do you remember what the formula is for airway resistance? Formula for airway resistance is P1 minus P2 divided by flow. So it's the beginning pressure in a tube minus the ending pressure, and the difference between those two divided by flow. Now that's my respiratory Pythagorean theorem. I know this, and this makes perfect sense to me. A beginning pressure minus an ending pressure divided by flow, that's resistance. All right? And that's the way you need to think about systemic vascular resistance. Okay, the same way. It's just a beginning pressure and an ending pressure divided by flow. And I'll show you what I'm talking about. So here's SVR, vascular resistance. It is a beginning pressure minus an ending pressure, and again, times a factor divided by flow. And so think about this for just a minute. In the systemic circulation, the beginning pressure is in the aorta, right? Well, that's the blood pressure right here that's in the aorta, mean arterial pressure. That's P1. Well, what's the ending pressure in the systemic circulation? Well, it's right before it goes back into the right ventricle, right atrium. That's P2, right? P2. And so that is basically the CVP pressure. So it's a beginning pressure, ending pressure in that circulatory system divided by the flow, which is the cardiac output, and that's going to equal 80. not equal 80, times 80. That's the conversion factor. So once you've done all this, you multiply it times 80, and that gets you your units that you need to have for systemic vascular resistance. Same thing for pulmonary. It's a beginning pressure, a P1, minus an ending pressure, divided by flow times the conversion factor. So what's the beginning pressure in the lung circulation? Well, it is the pulmonary artery. So the mean pulmonary artery pressure is P1. What's the ending pressure in the lung circulation? Well, it is the pulmonary capillary wedge pressure, which is the pressure of blood going into the left atrium, right? So P2. So P1 minus P2, mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by flow. That's going to equal, that times the 80 is going to give me my vascular resistance. Okay, and we'll practice this a couple times. All right, so we're in the stretch here. We got just a few practice questions we're going to do on hemodynamics and calculations, and then we'll be wrapping up the day. So there'll be some time there to ask some questions at the end if you need to. All right, so let's look at the first one here. The first question is, if a patient's pulse pressure is 40 and the systolic pressure is 140, what is the diastolic pressure? Well, again, the formula for this is the systolic minus the diastolic. So if we don't have the diastolic pressure, we know that the pulse pressure is 40 and this is 140, that means that 100 has got to be the systolic pressure, right? I mean the diastolic pressure. Okay. Next question. The patient's being monitored with a pulmonary artery catheter. The following measurements are recorded. Now, we're going to give you one of your first techniques or strategies in taking this test. And that is, anytime you see a series or a list of things following a statement, I want you to skip that. Don't look at it, okay? So we've got a list here. We're going to skip over it. Let's go to see what the question is. The question is, what is the mean pulmonary artery pressure? Oh, mean pulmonary artery pressure. Well, I remember my mean pulmonary artery pressure formula is this. It's 2 times the diastolic pressure plus the systolic divided by 3. So we want the mean pulmonary artery pressure. So I come up here to my pulmonary artery pressure. I take my diastolic pressure right here, 25. I multiply that times 2. That equals what? 50. Okay. And then I'm going to take my 50 and I'm going to add it to my systolic pressure, which my systolic pressure here is 50. So 50 plus 50 is what? 100. That's right. And then I'm going to take that 100 and divide it by 3. Well, 100 divided by 3 is going to equal what? That's right, 33. Okay. So that's how I would do that one. Here's another question. Patient being monitored with a pulmonary artery catheter. The following measurements are recorded. Again, I've got a list. I'm going to skip the list and I'm going to go down and what is the question? What is the patient's pulmonary vascular resistance? Oh, resistance, airway resistance, P1 minus P2 divided by flow. Okay, so what is my vascular resistance? I got to know a beginning pressure and an ending pressure and then divide that by flow. And I'm in the pulmonary circulation. So I got to look at only numbers that relate to pulmonary circulation. So here again, here's my P1 minus P2 times the 80, or excuse me, P1 minus the P2 divided by flow times the 80. And so what is my beginning pressure in the pulmonary circulation? That is the pulmonary artery pressure. What's my pulmonary artery pressure? It's 18. Okay, so 18 minus the ending pressure, which is the wedge pressure, which is going back to the left heart. So I take 18, subtract 8, that's 10, right? So I've got 10 up here, and then I'm going to divide that by 5, which is my cardiac output, right? Cardiac output is 5, so 10 minus 5 excuse me, 10 divided by 5 is 2, right? And then I'm going to take 2 and multiply it times 80. That is what? Yeah, 160. I mean, yeah, 160, right? Yeah. So the answer here is 160. 2 times 80 is 160. And that's how I would do that particular one. So again, airway resistance, P1 minus P2 divided by flow, vascular resistance is the same thing. All right, patients being monitored with pulmonary artery catheter. The following measurements are recorded. Again, I've got a list. I'm going to skip the list. And then I go down here to the question. It says these results are most indicative of. Now, anytime they ask these results are most indicative of, they want to know what the problem is. So remember back to my circle algorithm, my circle diagram. Those are the things that listed my problems. So they're asking me, what's the problem with this patient? So I'm going to go back in here and find the double arrow. I got to look at my pressures and find out which ones are up. So again, I look at the CVP and it's at 10 centimeters. Remember what normal pressure is in centimeters for the CVP? It's 4 to 12. So how is this one? Oh, that one's okay. Okay. And then my PAP is supposed to be 25 over 8. Well, whoa, this is way up. So there's some double arrow right there, action going on. My wedge pressure should be what? 4 to 12, so that's okay. And then my mean arterial pressure should be around 90, so that's okay. So where's the double arrow? Right here with my pulmonary artery. So what kind of problem do I have? I've got a lung problem. So what I got to find is something in the answer that says lung problem. Remember, we gave you all the examples of the lung problems they may ask you. So let's go down here. What is the problem? Where's the thing that says lung? Ah, there it is right there. Pulmonary embolism. Yes, that's the right answer. All the rest of this stuff is not lung problem. Okay? So that's how you figure out how to answer the question about what's the problem, by looking at the blood pressures. Here's another one. Patients being monitored with a pulmonary artery catheter. Following measurements are recorded. Again, I got a list. I'm going to skip it. Go to the question. It says these results are most indicative of. So they want to know what the problem is. Okay, let's find my double arrow. Is it my CVP? No, that's perfectly fine. It's between 4 to 12 centimeters of water. How about my pulmonary artery pressure? No, 25 over 8 is perfectly normal. My wedge pressure, however, that should be around 4 to 12. That is way up. My mean arterial pressure is down a little bit, and then my cardiac output's down a little bit. But this is the one that's got the double arrow. So my problem is a left heart problem. Left heart problem, because that's my wedge, right? So which of these answers is a left heart problem? Well, if you said congestive heart, you would have been correct, because all the rest of the stuff is right heart stuff, except for this, it's just hypovolemia. Okay. Now, I don't know about you, but I was getting excited about this time whenever Tom was going over this. So patient question here, patients being monitored with a pulmonary artery catheter. The following measurements are recorded. Again, I've got a list, I'm going to skip it, and then I get down to the question, said these results are most indicative of. So what's the problem? All right, let's go back up here. 12 millimeters of mercury CVP. Now they've changed the units on me here. So this should be what? 2 to 6, right? So that's a double arrow right there, okay? The PAP should be 25 over 8. That's a double arrow right there. The wedge pressure should be 4 to 12, right? That's a double arrow right there. Cardiac output should be 4 to 8. That's a double. Well, that's not, actually that's okay there, the 7 liters a minute. But the point is that all three of these are up. All right. So if everything is up, what does that mean? Yeah, I've got hypervolemia. I've got too much fluid on board. Okay. Now, If we take this same question and change it just a little bit, they could do something like this. Again, all these pressures are the same that we just looked at. Okay, so all of these are up. We've already noted that. But here's the next question changed. What should the therapist recommend? This is an analysis question. So now they're saying, okay, what's wrong? Well, the problem is the same. It's still hypervolemia. But what should you do to fix it? Hypervolemia should be fixed by doing what? Giving furosemide. That's right, furosemide. So furosemide should be the answer. What do I do to fix it? Where's furosemide? Well, if you pick this one, then you're right on track, because again, some of you would have looked at that and said, well, they lied to me. Furosemide's not even in the answer. But hopefully you can make the leap between furosemide and diuretic therapy, okay, to get that right. All right. Next question, the patient is being monitored with a pulmonary artery catheter. The following measurements are recorded. Got a list, I'm going to skip it. Go down here. These results are most indicative of, so they want to know what is the problem. Okay. Look at my CVP, that's up, definitely. My PAP is okay, my wedge pressure is okay, cardiac output's okay, but this is up. So I've got a right heart problem. I'm looking for something in the answer that says right heart. When I look at my answers, where's the thing that says right heart? There it is right there. The tricuspid valve is on the right heart. Okay. All right. So those, yes, go ahead.
I'm going to stop you there. Could you go back to the first question in this section? It was the one where you gave them the systolic pressure and the pulse pressure, I believe.
The pulse pressure? Yes.
Yeah.
I can certainly do that. Let me go.
A little quick review as you go backwards.
This one.
That one.
Okay. So remember that the systolic pressure, the pulse pressure is systolic pressure minus diastolic pressure. So this is just basically solving for an unknown. So there's a couple ways that you could do this. You could just set this up algebraically, all right, and solve it that way. Or you can look at the parts that you don't have and find out what's missing. So that's what I did. I basically said, all right, this is the pulse pressure here of 40. And this is the systolic pressure of 140. So the difference between 40 and 140, there's got to be 100. Okay. And that's basically how I came up with the answer. And I'll pause here to see if there needs further discussion. This is where I wish I had a something you could draw on the screen, Tom.
Well, there is a way to do it, but every time I try to do it, I lose my slides.
Oh, well, I ain't doing that. Is that what this little thing is right here? Drawing tools? Must
Yeah.
be. Any response? Did that clarify, or did that?
Well, somebody asked if you could, it would help if they could see you work out the problem, like write it on a whiteboard. So.
Yeah. Okay. Well, so I didn't work it on a whiteboard. I just did it in my head, is what I did, because I just know, looking at those three numbers, there's one number that's missing. If I just take this 40 away from this 40 here, that's going to leave me with 100, and that's the number that's missing.
Yeah, I would do it the same way. When I look at this, I say, well, 140 is the top number.
Right.
The difference between the top number and the bottom number is 40. So that's where I get the 140 minus 40, which would equal 100.
Right. Yeah. Okay, well, hopefully that helps. If it doesn't, stay tuned for the question and answer period at the end of the seminar today. We'll try to work something out and try the little draw tool and see how that works. Okay, so we will move back forward. Okay, so what we're going to do now, folks, is we're going to, if you'll go back to the first part of your book where the pretest is, we're going to go over the questions that relate to patient assessment, and then we'll be done for the day, okay? Unless you've got some other questions. So this starts on page 3 in your study guide. And question number 1 says, which of the following structures are visualized in a patient with a Mallampati class 2? And so basically this is kind of a rote memory one, recall. So you just have to know that it's letter B here. Okay, those are the 3 structures. There's only one structure that's missing out of all of them, which are basically the pillars or whatever. Okay. Number 2, an elevated brain natriuretic peptide or BNP level will be consistent with a diagnosis of, most of you remember that one, congestive heart failure. That's right. And it has to be greater than 300 in order for it to indicate the congestive heart failure, right? Number 3, while monitoring pressure with the Swan-Ganz during insertion of the Swan-Ganz catheter, the respiratory therapist notes the presence of a dicrotic notch. So we're putting in the pulmonary artery catheter, and we got dicrotic notch. Remember, the only waveform that has a dicrotic notch is the pulmonary artery, right? So this indicates that the tip of the catheter is inside of the what? Pulmonary artery. Okay. Number 4, the respiratory therapist has measured the exhaled nitric oxide or FeNO of a patient with asthma. And remember, this measurement gives us an indication how well our steroid therapy is working. The therapist notes a decrease in the patient's FeNO levels from his last visit 1 month ago. So it's decreased. That's a good thing, right? These results would be consistent with the increased use of what? And again, steroids are the medicine that we're monitoring the efficacy of. Okay. Number 5, I love this one. The therapist discovers that the patient has dyspnea and diminished breath sounds with a flat percussion note on the left. So I've got something going on the left, and the chest radiograph indicates a tracheal shift to the right. Okay. Which of the following disease states would the therapist suspect is being affected? Now, most of you probably zeroed in on that tracheal shift to the right and just thought pneumo. But the percussion note, okay, is flat. So that can't be a pneumo. A pneumo has to be hyperresonant or tympanic. So again, this is what I was telling you. Anytime they give you that percussion note, pay close attention to it because it's going to point you in the right direction. So when they go over here, notice they offer the pneumothorax, but that would not be correct because the percussion note is incorrect for that answer. So it would have to be the pleural effusion. Dullness indicates fluid or lack of air, okay? Question 6, patients being monitored with pulmonary artery catheter. The following measurements are recorded. This is just like we've been doing. So I got a list. I'm going to skip that, go to the next, or go to the question. What is the patient's systemic vascular resistance? So I will go back over here to this, and now you see I've shown you the formulas that you should be thinking about. This is the resistance, airway resistance or vascular resistance formula, P1 minus P2 divided by the flow times 80. Okay, and so it's systemic. That means it's going to be coming out of the aorta, which is going to be my mean arterial pressure, and then the ending pressure in the systemic circulation is going to be the vessel just before it goes into the right atrium, which is the CVP. So that's P1, P2 divided by cardiac output times 80. So mean arterial pressure is 84. Subtract the CVP of 4, so that's 80. Okay, so this number is 80 divided by 4 is what? 80 divided by 4 is 20. And then 20 times 80 is 1600. Okay, so there's our answer right there, 1600. All right. I love this one too. 32-week gestation age infant receiving mechanical ventilation with time cycle pressure limited ventilator at the following settings. And you got all this list, so we're going to skip that and go to the question. It says the respiratory therapist notices the TCPO2 reading suddenly drops to 39. There have been no changes in ventilator settings. However, the patient is cyanotic, the trachea is deviated to the right, and the breath sounds are absent on the left. The respiratory therapist should recommend which of the following. So here again, the problem is we've got low PaO2, we've got cyanotic patient, we've got a shifted right trachea, and the breath sounds are absent on the left. That sounds like a pneumo, okay? And in fact, the thing to help us diagnose a pneumo would be the transillumination. But what I love about this question is, notice how I did not have to look at any of this stuff over here. And most of us would have gotten this question where you started looking at all this stuff, analyzing it, thinking about it, and then it had nothing to do with the question that's being asked over here. What should we recommend? It's got nothing to do with ventilator setting. It's got to do with recommending diagnosing the problem, which is the pneumothorax. Okay. Following endotracheal number 8 there, following endotracheal intubation, patient with myasthenia gravis, the respiratory therapist reviews the following x-ray. And again, I can look at this and see that it's in my right main stem. So this one's collapsed. So definitely I've got my tube down too far. I need to withdraw it. So the answer is to pull the tube back some, okay? Now they don't say pull the tube back, but here's close as they get to that is withdraw the tube slightly. Okay. Yeah, so the only contraindication to albuterol is apnea. Everybody else gets it. That's right. Okay, now I say break, but what I'm going to do is I'm probably going to stop here because I've only got about 30 minutes left till we're supposed to end for the day, and I know I can't get through the next section in that amount of time. So Tom, I'm going to kind of let you chime in here and let me know if there are any other questions that I need to go back over, or if there's a question about something else that I said that didn't make sense. I can kind of review that with folks. I know this is a very, very long section, but it's a very important section, as I said before. So how are we doing, Tom?
I don't have any unanswered questions regarding this last section. So I don't know if you want to just kind of open it up, and they can do one of two things. They can either type the question, or the other thing is if they want to raise their hand, we can unmute them.
Yeah.
Okay.
Yeah, that's a good idea. So,
all right.
Yeah, that's a good idea. So if you have a question, you want to type it, that's fine. If you want to raise your hand, then let's see.
I have a question. Somebody
through.
wants you to go over a graph, and I'm trying to find out which graph it is.
Okay. Oh, here I got a hand. Let me see if I can get this hand.
Pulmonary artery graph, pulmonary artery position graph, the one with the where you can tell if the where the tip of the tube is, page 61. Thank you, Nicola.
Okay. All right. So let me do this. Let me go back and answer that one. Gonna be down here somewhere. This one.
Yes, that one. Yep.
Okay. So the main point of this graph, folks, is to make sure, one, that you know that the pulmonary artery has a dicrotic notch, and that's how you can identify that's a pulmonary artery waveform. And again, the A line has a dicrotic notch also. But if you know that you're looking at a pulmonary artery catheter and you see the dicrotic notch, then it's definitely the catheter is in the pulmonary artery. All right. Over here, the end of the catheter is actually in the right ventricle because there is no dicrotic notch. Over here, of course, is the CVP because the CVP is next door to a waveform that there is no dicrotic notch. As opposed to here, the pulmonary capillary wedge pressure is definitely, this is a pulmonary capillary wedge pressure because you got dicrotic notch on either side of it. Okay, and so my point here for you guys in looking at this is to make sure that you can identify what's a pulmonary capillary waveform, and the way you can do that is by knowing that it's either got a pulmonary artery pressure waveform on the left side of it or on the right side of it. And if it's a CVP pressure waveform, then you're going to have a right ventricular pressure to the right of it, but no dicrotic notch. How'd I do there?
That sounds good. If I could just add,
Sure.
Another way to look at this is estimate the pressures in each of those four parts. So if you start over on the far left, if you look at the scale that goes from 0 to 40, in that first one, the number is in the 2 to 6 range. Well, 2 to
Right.
6 has got to be your CVP.
Right.
The next one over to the right is about 25 and it goes down to 0. Well, that's right ventricle. The third one, pulmonary artery, is 25, but you do have a diastolic pressure of about 8.
Hmm.
And then that last one, it looks like the CVP, but it's higher. And that's about 4 to 12 or so. So that's my
Right.
way.
Right. And so, but the only thing with that is, Tom, is that this CVP could be illustrated as an elevated CVP pressure.
It could, yes. Yeah.
And then if they did that, the only way you would know that this was a CVP versus a pulmonary artery catheter or pulmonary capillary wedge pressure is you'd have to look at the waveform next to it.
Yes, I agree. Yep.
So they'd have to give you both those pieces. Now, if they said this was a normal waveform for a patient was normal, then what you're talking about would absolutely be, work. That's right.
Okay. All right. Let's see. We had a couple of hands up. Let me see if I can find them.
Yeah. How do you find the hands that are
Click
up?
on attendees. Okay. Jacqueline, I'm going to unmute you if you have a question for John.
Anybody there?
Yeah, see, it won't let me oh, here, hang on. There we go. Okay. Jacqueline, are you there?
Let me try it. See if I can do it. It says you're self-muted.
Yep, Jacqueline, yeah, you may need to unmute on your computer or
Right.
your tablet. Okay, well, we'll come back to you, Jacqueline. There was another one. Let's see if I can find it. Stephanie Ramey. Stephanie Ramey, do you have a question?
But she's got a hot mic.
Yeah.
But we can't hear her.
Yeah. Okay, I think those are the only two questions. We're up. Nope, got one more. Darnell. Darnell, if you want to unmute yourself. No, I don't hear Darnell. Okay.
Okay, so this is what I'm gonna do, folks. What I want to do is I want to give you guys, while we're waiting for some of this to people kind of get some of their questions together, maybe send them to Tom. Let me just say this. I want to give you a homework assignment for tonight. And the homework assignment I want to give you for tonight is to do absolutely nothing. Please do not get your study guide out and start going over this stuff and all that. I mean, you've had a full day of this kind of stuff. And if you really want to be on your best game tomorrow, try to take a break from this, get a good night's sleep. And whenever we rejoin tomorrow, same time, 11 a.m. Eastern Daylight Savings Time. We'll start at 11, and you'll be in a much better frame of mind to go through the stuff we got to do tomorrow, because tomorrow we'll be looking at pulmonary function stuff and let's get started in some mechanical ventilation stuff too. So the main thing is tonight, take it easy. If you can, let somebody wait on your hand and foot and pamper you a little bit. But I would strongly not advise you to start doing any studying at this point in time. Again, we're trying to identify the information that you need to be working on after you're done with the seminar. That's what we're trying to do here, and to give you some strategies and some helpful hints on how to do some of the more difficult processes for coming up with answers. Is anybody else able to get on and to vocalize or to submit a question that I need to?
Okay.
I will stay on here.
Erica, are you there?
I'm here.
Okay, Erica, go.
Erica, hi.
Hello. Real quick question. On page 821, can you go real quick if there's any highlighting sections that we need to put on? I missed that page. I had trouble with my internet. 821, yeah.
821. Okay, so top of the page, highlight letter B, and then highlight numbers 1 down through 4. Okay, and then bottom of page 21, letter C, highlight numbers 1 and 2, letter B under number 2, and number 3.
Okay, perfect. On the next page, 822, anything that we need to highlight on that one?
Yes, under letter D, number 1, number 4, number 5, number 6, number 7, and under number 7, letter F, and under number F, number 1 and number 2, number 8, number 9, and under number 9, letters A and B.
Perfect. Thank you very much. Appreciate you guys.
All right, no problem.
Okay, next one is Candace. Candace, if you want to unmute your computer at your end as well, click on the microphone. There you go.
Yes, can you hear me?
We can hear you.
Okay,
Thank you for calling in. Where are you calling from?
California.
Ah,
Well, you
okay.
sound pretty good from calling from California.
Well, thank you. Well, I had a question as well on patient assessment A58. My internet was having troubleshooting issues as
Okay,
well.
A58. Let me get there.
It's the last of the hemodynamic, the monitoring.
Yes,
Just what areas should I have highlighted?
Highlighted on the bottom or the whole page 58?
E and down. So
E and down. Okay, so from E, you should have number 1, number 2, number 3. Under number 3, letter A. Under letter A, 1, 2, 3, 4. Letter B, 1, 2. Under letter B. Letter C, 1. Under 1A. And then under Roman numeral 1, the drug nitroprusside.
Okay.
And then under number 2, vessel dilation, Letter A, the drugs epinephrine, dopamine, and dobutamine. And you want to make a note next to epinephrine, not good if increased heart rate.
Okay.
And under dopamine, dobutamine, you want to make a notation there, more often used in ED and ICU.
Got it.
Okay.
All
And
right.
then letter F, systemic blood pressure,
Mhm.
under number 1, A, B, C.
All right.
Okay.
Thank you.
You're quite welcome.
That's it for now.
All right. Great. Thanks.
Thank you.
All right. Anybody else? Boy, Tom, you're such a technological whiz here, I'm telling you.
I think that's it.
All right. Now, let me just say one thing for those of you who may be hanging in there. If there's a question that you didn't want to ask online in front of everybody, please feel free to either text me or to call me on my cell phone like I gave you. I'd be happy to talk to you over the phone. That way you don't have to feel embarrassed or anything like that. I am totally here for you for the next 4 days. And so again, if there's, if because of the format, we're not able to make a connection on how to do something, I'm certainly willing to, take a phone call or something like that in the evening to try to work you through it, through a different way and everything. So I want to thank Tom for helping. And just the last check, are there any other questions, Tom, that we're missing that we can't?
Nope, none that I can see.
Okay. Is there a way that I can see without scrolling or to get a report as far as who was all here? I've kind of
Yes,
went through the
there's-
list
yeah,
and scrolled
there-
through it, but is that
I
through
can
the,
email you that.
oh, okay.
The instructions for doing that, yeah.
Yeah, instructions for doing that would be perfect because then
Yep.
I can just go back on later on and run that report or whatever. That would be
Yep.
great.
Yep.
Okay, perfect. All right. Well, everybody, I hope you have a great evening. We're going to go ahead and sign off. We will start promptly at 11 o'clock tomorrow, and y'all be safe out there. Thank you so much. Thanks, Tom.
No problem, John.
All right.
Thank
Talk
you,
to you in
guys.
the morning. Bye.